Assalamu alaikum. This is Dr. Mariam Al-Abdallah, a professor in orthodontics at the University of Jordan and a senior orthodontic consultant at the Jordan University Hospital. This is going to be our first lecture out of 3 talking about interceptive orthodontics. Our main reference is chapter 3 from An Introduction to Orthodontics by Simon Littlewood and Laura Mitchell, 5th edition, but there will be some extra readings involving clinical guidelines and some articles. So this is our main reference, Management of the Developing Dentition, Chapter 3. And let's start by giving definition of what we mean by interceptive orthodontics. So according to Richardson in the 1982, it's defined as the prompt treatment of unfavorable features of a developing occlusion and achieving a satisfactory result by simple mechanics later, thus reducing overall treatment time and providing better stability and functional and aesthetic results. So basically, it's an early intervention, which means that this is something that should be done usually for children between the age of 8 till 10 on average, right? Take into consideration the individual dental variation regarding the dental development. And again, these children are supposed to be in the mixed dentition. So again, we are still talking about the stage of development of the occlusion, dental development, to be able to provide such treatment or an intervention. Now, the purpose of having an interceptive orthodontics is either to fully correct the developing malocclusion, and this is true for about 15% of the cases, or improve these cases, which is true again for 49% of the cases, and unfortunately the rest of the cases will have minimal benefits. But if we look at 15% of these patients where we can fully correct the malocclusion at an early age, and the 49% of improving the severity of the features of the malocclusion, I think this is worth applying an interceptive measures at an early age. Right. So what do we need to carry out an interceptive orthodontics? Of course, first of all, we need to be able to differentiate between what is considered a normal dental development, occlusal development, and what's not considered normal. So we need to have the knowledge. This has already been given to you with several lectures, especially related to dental development, craniofacial growth and development, and etiology of malocclusion. The second step is to carry out systematic examination for all your patients, regardless of their teeth complaint. So we don't focus only on treating a tooth or several teeth where the patient is complaining of. We need to look at the general development of the occlusion. We need to be able to identify any problem early. And again, here we're talking about children with usually in the mixed dentition. So we need to be able to diagnose the problem. Next is we must understand the consequences of no treatment. We need to understand why we are applying an early treatment for these children. What's the benefit? Okay, what are we trying to prevent? And finally, of course, we need to know how to apply these measurements. We need to know how to treat these cases. At least, you need to be able to diagnose the problem, give advice to the patient and the parents, and refer if unable to provide the treatment yourself. So this is the least you could do for such cases. So we have, as we said, 3 lectures. The first will talk about natal tooth, supernumerary teeth, hypodontia, early loss of deciduous teeth, retained deciduous teeth, and non-nutritive sucking habits. In the second lecture, we will talk about infra-occluded primary molars, eruption cysts, failure and delayed eruption, first molar of poor prognosis. Third lecture, we will talk about spacing, crowding, anterior crossbite, posterior crossbite, and increased overjet. So these are the main problems that could benefit from an early treatment in order to fully correct or let's say reduce the severity of such features of the malocclusion and make the future treatment necessitate less time, less complexity, maybe less expensive, or as we said, 15% will need no treatment in the future. Right, so as you know from your lecture on local factors, you took 2 lectures on local factors, so you'll find lots of repetition in these in the interceptive lectures, because most of the interceptive treatment actually is trying to solve the problem caused by local factors. All right, so let's start with a natal tooth. Natal tooth is a tooth that is present at birth. It's called neonatal if it appears soon after birth. Majority of the cases, this tooth is part of the normal deciduous dentition. Rarely, it could be a supernumerary. Now, if this tooth is firm, there is no risk of inhalation, and it does not affect breastfeeding, then our management is to do nothing, especially radiographs. Don't take radiographs. It's not necessary. It's not justified. It will not affect your treatment. So if it's firm and it does not affect breastfeeding, then just do nothing. Reassure the worried parents, that usually the parents are worried about problems and abnormalities. Just reassure them, and you have to record this in the patient's file, in the patient's dental records. But if this early erupting tooth is suffering a bit of mobility with risk of inhalation, or if it affects breastfeeding, then the best management is to extract it. And again, this could be one of the deciduous teeth that will erupt later. So this management has to be properly documented in the patient dental record, so that later on the parents or the dentist who's going to take over taking care of this child will actually know that this is not a case of tooth agenesis, it's a case of an early extraction. Right, now we come to supernumerary teeth. Can we do something during the mixed dentition to solve this problem? Well, it depends really. Now, just to remind you, supernumerary tooth is any extra tooth to the normal complement. It could be actually a whole tooth that looks as a normal tooth, or it could be a part of a structure of a tooth, dental structure, let's say. The permanent dentition is affected more commonly than the primary dentition, and males are affected more commonly than females. And the most commonly affected area is the anterior region of the maxilla. Now, and usually if the primary dentition is affected, then usually the permanent dentition is affected as well. Right, and these extra teeth are classified according to their position and according to their morphology, and I believe that you already know that. So if they are erupting between the incisor, the central incisor, we call this mesodense. If it's erupting beside palatal or buccal to the, teeth, then this is called paramolar. If it's erupting distal to the normal set of molars, then it is called distomolar. According to the morphology, we have the conical, and the conical is usually a small, let's say, pig-shaped crown, and usually it has a root, and sometimes it is presented inverted in the bone, and it can erupt, and it rarely causes problems with eruption of the adjacent teeth. Right, and 10% of the median diastema are actually caused by this type of supernumerary, the conical type of supernumerary. If it erupts, usually it's a mesodense, and usually it erupts between the central incisors. It can cause aesthetic problems, it can cause crowding, displacement of the adjacent teeth, but it rarely causes failure of eruption. Now, what's the management? If I can see it clinically, then it should be extracted as soon as it erupts, okay? Other cases, usually it's diagnosed by accident because it will stay in the bone and it will cause no problems. So this is an example of a patient who came to our clinic in the late mixed dentition, as you can see. So he's most probably like 12 years of age. You can see the E and the just lost E on the upper right side. And the patient is coming because of the overjet, so we took an OPG and we looked at this area here against the root of the upper right central, and we had to take another view because it wasn't clear. And to our surprise, there was a conical supernumerary sitting there, inverted, luckily causing no problems. It did not prevent eruption of this central incisor, but because we're planning to go for orthodontic treatment, it had to be extracted before any active orthodontic treatment is carried out because there will be risk of root resorption of the adjacent teeth. Tuberculous supernumerary usually is barrel shaped, has no roots, usually it comes in pairs, and it does cause problems. It doesn't erupt into the arch, but it can cause failure of eruption. So as soon as it's diagnosed, it should be extracted, and usually it is diagnosed by looking at failure of eruption of the central incisor. So this is, for example, a case, a patient in the mixed dentition. You can see the 4 lower incisors fully erupted, upper left incisor, both lateral incisors are fully erupted. So obviously there is a problem. There is a problem because we have problem in symmetry of eruption. So the left side erupted, but the right side hasn't erupted. And we have a problem with the sequence of eruption. The lateral incisor erupted before the central incisor. So this should guide us to an early diagnosis if the patient is actually coming to his 6-month review. Then this should be diagnosed really early. And as you can see, there is a small tooth structure here that appeared to be a tuberculate that needed to be extracted before the tooth could come through. If this treatment was delayed, what happens is that we will have loss of space, and we will need a further step of orthodontic treatment to reopen the space and then maybe traction of the incisor to allow its eruption. So this is an example of a patient who came also in the late mixed dentition. The patient was lucky he had a tuberculate, but this tuberculate did not prevent eruption of the central incisor. But if we are planning for orthodontic treatment, and we did, so this supernumerary tooth has to be extracted before any orthodontic treatment is taken. Right, supplemental supernumerary is a tooth that exactly resembles the real tooth, real to the adjacent teeth, of course. So this is an example of an extra premolar. So you can see the 4, the 5, and in between there is a whole premolar sitting there. Usually the most common supplementary supernumerary is a lateral incisor. And most commonly it is, if erupted, it can cause crowding, or it could still stay impacted, it depends. Now, if it erupts, causing this crowding, then the management is to extract one of the incisors. Now, if they are all are of good prognosis, then we need to extract the most severely displaced tooth. So you can see here, this is the canine, this is the canine, and in between we have 5 incisors. So if they are all the same in terms of dental health, in terms of soft tissue health, then we extract the most severely displaced incisor. But if one of them is compromised, for example, due to trauma, due to gingival recession, pocketing, periodontal pocketing, endo treatment, or filling, caries, then basically this tooth has to go. The tooth with the most severe prognosis has to be extracted in order to relieve crowding and to align the teeth. Okay, odontomes is another form of supernumerary tooth or structure of dental structure, and it could be complex or compound. Usually this type of supernumerary does not cause many problems. It may cause failure of eruption or displacement of adjacent teeth, but usually its finding is by accident, diagnosed by accident. Now, if it's there causing no pathology, no problem, we can leave it and get biannual radiograph to assess its position, and of course properly inform the patient and properly document this in the patient's dental files. If you're planning for any orthodontic treatment, these structures have to be extracted before you go for any orthodontic treatment because they will carry out the risk of root resorption. Right, so just to sum up the management of supernumeraries, the management depends on their clinical presentation. Okay, so the supernumerary could be fully erupted into a crowded arch, or it could be impacted, carrying the risk of pathology or the risk of causing failure of eruption of adjacent teeth, or it could be asymptomatic, okay, just being diagnosed by accident. So this is an example of fully erupted supernumeraries. So these has to be extracted. Residence has to be extracted as well. And as we said, this is an example of a supplemental supernumerary. So you extract the most severely displaced tooth or a tooth with the most severe prognosis. This is an example of a patient who had two lateral incisors. Clinically, they looked the same, so we took periapically. You can see the one that is more distal had dilaceration, so we had to extract the one that was more distally placed, as you can see here. So this had to be extracted. A patient who had a supplementally central incisor, so he had actually had 3 central incisors, all of good prognosis. So of course, the extraction would be the incisor of the most severe position, which is this one here in the middle. Okay, so if it's fully erupted, then this is what the management should be. If it's impacted and causing problems, for example, this patient here, he can see that the 4 lower incisors are fully erupted, the upper right incisor again fully erupted, the lateral incisors in the upper arch are fully erupted, which means that the upper left central incisor is suffering delayed eruption. There is a problem. There is a problem here. And this radiograph was taken first, and you can actually see the A retained, the B retained, and there are 2 extra tooth structure. One that is classified as tuberculate and the other that is classified as a conical, and this is the central incisor. And of course, the management for a supernumerary that is causing problems with eruption is extraction. So we extract these 2 deciduous incisors, and we extracted the tuberculate and the conical supernumerary. And then after that, the patient was reviewed to see the progression. As you can see, the management was a little bit late because we had loss of space. So we had to interfere by reopening of space and check the response of this tooth with a possible surgical exposure and orthodontic extraction for this tooth. Another example of a patient that had a supplementary tooth that is causing problems. So as you can see here again, in the upper arch, we have both central incisors fully erupted and both laterals are erupting. The upper right lateral is partially erupted. In the lower, we have both central incisors, the lower left lateral, but the lower right lateral is not there. There is a problem and there is bulging. There is partially erupted something here. So the patient had to go for a combined CT scan, and actually what we found was 2 extra lateral incisors in the lower right quadrant and 2 lateral incisors in the lower left quadrant. So we had 2 extra laterals, one on the left, one on the right. On the left side, it did not interfere with the eruption. On the right side, it did. And this is what caused the diagnosis. Otherwise, it would have gone unnoticed. So the management, as you can see, if we have a problem, and if the tooth is supplementary, which means that it has the shape that is exactly the same as the permanent tooth, then we extract the most severely displaced. So we extracted this one palatally, and we review the eruption of the one that is within the line of the arch. And this is on the right side. On the left side, we had to extract the one that was impacted palatally as well. All right, so as you can see, this is the extra tooth. Right, yeah, so we have 3. We have the central and 2 laterals, and we have to extract the one that is more severely displaced. Again, another example of a patient with a supernumerary that is causing a problem. So this radiograph was taken first. You can see this is a retained A, and this is a central incisor with delayed eruption. because the laterals are fully erupted. So there's something wrong with the symmetry of eruption, and there's something wrong with the sequence of eruption. So this supernumerary had to be extracted, and we had to wait for response of this tooth. Guidelines for the management of failure of eruption of the central incisors will be discussed in the second lecture. Right, so this is later on after extraction of the supernumerary and follow-up of the patient. Right, so if the supernumerary is impacted and there is no pathology, it is asymptomatic. Well, for example, this patient here that we talked about, if this was asymptomatic and the patient is not planning for any orthodontic treatment, then we have to inform the patient properly, give them the option of extracting it now, or just go for review biannual, twice a year. Review its position just to make sure that it's not causing any pathology, it's not moving and causing resorption of adjacent teeth. It's better to extract it as the problems caused by it are usually irreversible. And if you're planning for orthodontic treatment, then definitely it has to be extracted before any tooth movement is carried out. Right, now we come to hypodontia, which is totally the opposite, which means congenitally missing teeth. This problem is more common in females than males, and in the permanent dentition than the primary dentition. If you have a congenitally missing primary tooth, then the permanent tooth is missing as well. Now, the classification and the epidemiology, you already covered this. We need to talk about the management. Now, the problems that could be produced by such a problem is usually a central line shift, spacing, malposition of adjacent teeth, retained deciduous teeth, of course, with risk of submerging, over-eruption of opposing teeth in the maxillary arch if the missing teeth are in the lower arch. And again, the consequences of hypodontia will depend very much on the severity of hypodontia itself. Now, if the missing tooth is in the anterior segment, then luckily this case will have a good chance of early diagnosis because the tooth is missing in the aesthetic zone. If the tooth is missing in the aesthetic zone, then usually the child and the parents will seek treatment early. Now, in the lower arch, if we have a missing incisor, then we try to preserve the to maintain the deciduous tooth as long as possible, because this will maintain a healthy periodontium and it will maintain and preserve healthy bone, and this will improve the success of implants later on if needed. If the case is suffering class 3 malocclusion, then again we maintain the deciduous teeth because we can use this later for orthodontic purposes to camouflage the class 3 malocclusion. Okay, this is an example of a patient that had congenitally missing lower central incisors. As you can see, these are retained A's. Right, so we closed all of the spaces and we opened the spaces for these two. We maintained the deciduous teeth because the patient was not old enough for a permanent, for an implant. So once she's ready for an implant, then these two could be extracted and we can have an implant to replace the central incisors. So deciduous teeth has to be maintained as long as possible. In general, any patient with hypodontia should be referred to an orthodontist, but these are the general guidelines. Okay, so this is the patient before. As you can see, this patient after orthodontic treatment. We closed all the spaces, only we opened spaces for the lower missing central incisors for future implants. Now, in the upper arch, if the missing tooth was in the anterior segment, then it is important to investigate the risk of upper canines impaction, because according to the guidance theory, it says that the eruption of the permanent maxillary canines are usually guided by the distal surface of the roots of the lateral incisors. So if the lateral incisor is missing, or if it has a dental anomaly regarding to short teeth, peg-shaped laterals, then usually the canines eruption will be affected and we will have higher risk of impaction. So if you have a patient with congenitally missing lateral, the first thing you do in the maxillary arch. Of course, the first thing you do is you need to go for examination of the canines. Usually the buccal bulging of the canine, you start examining this at the age of 8, all the way to the age of 10. And usually in normal cases, you will have bilateral buccal bulging of the canine. If this is missing, or if this bulging is asymmetric, then you need to go for further investigation using radiographs and maybe further interceptive measures accordingly. So this is an example of a patient who presented with congenitally missing lateral incisors. On the left-hand side, you can see a retained B. On the right-hand side, you can see a retained C. And both laterals, permanent laterals, are congenitally missing. And you can see the upper canines are severely palatally impacted. The patient is in the permanent dentition, and these are only retained because of the impaction problem. So if he was young enough, let's say 8, 9, or even 10, then something could have been done to normalize the path of eruption of the canine, to help the canine to erupt more normally, or at least to reduce the severity of the impaction. Maybe we could not solve the whole problem, but at least we make the problem less severe and easier to treat later on. So these are the consequences of having no proper interceptive measures, no proper early diagnosis. Right, so another example of a patient who presented with an congenitally missing upper lateral incisors. The upper left canine has erupted in the place of the lateral. The upper left C is retained. The upper right B is retained. The upper right C is retained, and both 4 and 3 are in a transposition condition, as you can see. So this is a little bit complicated problem, but I'm just showing you this case to show you that this is a class 2 division 1 malocclusion, and congenitally missing teeth in the anterior segment actually could be used for reduction of the overjet and camouflage of the malocclusion. So extraction of the deciduous teeth was carried out. This was followed by overbite reduction and overjet reduction, and the closing of most of the spaces in the upper arch and reducing the overjet. So spaces were left around some of the teeth for later on build-up and some conservative work. Right, so if the congenitally missing tooth was in the posterior segment, unfortunately, usually these patients are presented with a late diagnosis because this is not the aesthetic zone. So usually you have an accidental finding. If the problem with the congenitally missing is in the lower arch, then we try to maintain the deciduous tooth to preserve bone for future implant. Or if the case is a class 3 malocclusion, then the orthodontist can use the space to camouflage the class 3 malocclusion. So we extract the deciduous tooth and we use the space for orthodontic treatment. If the congenitally missing tooth was in the upper arch, then again we try to preserve and maintain the deciduous tooth to preserve bone for future implants. Or if the case is a class 2 malocclusion with increased overjet, then the space of the congenitally missing tooth could be used for orthodontic treatment and camouflage of the malocclusion. So as I said, as a general rule, a patient with a congenitally missing tooth should be referred to the orthodontist for consultation. Okay, you can diagnose the case, you can give them advice, but the patient should see an orthodontist. So this is a case of a patient with congenitally missing lower right second premolar, and you can see the retained E there. Okay. Another example of a patient with congenitally missing second premolar are actually bilaterally, and you can see these are the E's. Nicely retained so that if we need the space for orthodontic treatment, it's there. If we need the space for an implant, then it's beautifully preserved with a healthy periodontium around it. Right, now we come to another problem related to the mixed dentition, which is the premature loss of deciduous incisors. Okay, now the incisors, when they are lost, they have minimal effect on the center line, minimal effect on the space available for the permanent dentition. So Don't take radiographs. Don't go for balancing extraction or compensating extraction. Don't fit space maintainer. These are not required for a premature loss of deciduous incisors. Okay? But what we need to know is, how was this tooth lost? Was it due to caries? Due to trauma? Now we're talking about, when we talk about trauma here, we're talking about a simple local trauma to the tooth itself. We're not talking about an aggressive trauma that actually affects the adjacent teeth and the bone and the soft tissues. This is not the case to be discussed here. We're talking about a single tooth that was lost due to trauma, single deciduous tooth. Okay? So if there are no severe or serious consequences of the trauma, no need for radiographs. Okay, because there's no justification. If you take radiograph, it will give you no further information. What we need to know is why this tooth was lost. And we need to record this properly in the patient's dental records, and we need to record this, report this properly to the parents. Because a tooth that is lost due to trauma can carry the risk of a Turner tooth to the permanent incisor. It can cause dilaceration and delayed eruption. It can cause deflection of the developing follicle of the permanent incisor, and again delayed eruption and impaction, and it can cause thickening of the gingiva, and again delayed eruption. Okay, so this patient should be kept under observation every 6 months, and if one incisor erupted and the other didn't, then we need to wait for 6 months up to 9 months max, and then we take radiographs and we go for further investigation. Patient with a history of trauma, we just wait 6 months, not more, and we look for the mobility of the deciduous teeth if it's there, just to check the resorption of roots of the deciduous teeth. So this is what should be done. But at the moment the patient comes to your clinic with a very worried parent due to a lost incisor in the mixed dentition, no active management is required. Just reassure the parents. Since we're talking about dilaceration, it's a condition where we have a bend or an angle within the crown, or between the crown and the root, or within the root itself. Okay, and there are two types: the developmental type and the trauma type. And clinically, this could be presented with delayed eruption, or it can go unnoticed, diagnosed by accident. Usually, if it's mild to moderate and it does not affect eruption, no need for any management. But some moderate cases, a very little number of severe cases, they will actually cause delayed eruption, and usually you will need to go for opening of the space, surgical exposure, attachment, and then go for orthodontic traction, active extrusion of the impacted tooth. If the case is so severe that the tooth, it's impossible to align the tooth, then unfortunately in severe cases we go for extraction. Right. On the other hand, premature loss of deciduous canines will need certain management, depends on the case, because an early loss of a C, it might affect central line, and it might affect the space available for the future permanent canine. And it depends on the age where the C was lost. It depends on the space condition of the arch, the amount of spacing, the amount of crowding, and the size of the arch and the permanent teeth themselves. Okay, so if the patient has spaced arch, usually the missing early loss of C will have little effect on central line, little effect on space condition in general. But if there is any degree of crowding, then we will have a high risk of central line discrepancy. In this case, we have to go for what we call balancing extraction. And balancing extraction means to extract the C on the other side. So if we have, for example, here an early loss of C on the upper right quadrant, we have to extract the upper left C in order to preserve the central line. Right? Otherwise, we will have risk of central line discrepancy, as you can see here. We will have risk of impaction, as you can see here as well. This bulge here is actually a canine. This is a first premolar. This is a lateral, so you can see there is hardly any space for the canine, and there is central line discrepancy as well. Right, this is another example of a patient who had an early loss of the lower left C. As you can see, both a 4 and 2 are in not only in contact, they're actually overlapping. And the lower canine is totally impacted. Now, the problem is not only, to be honest, it's not only an early loss of C, there's also crowding. But this crowding became localized in this area because of the early loss of C. You can see the consequences of center line discrepancy as well on an early loss of C on one side only. Right. So this is an example of a patient who received no proper interceptive treatment. This patient had an early loss of C, as you can see here. How do I know? Well, because the patient has crowding that is localized to the upper right canine and lateral incisor area only. So the problem in the etiology is usually a local problem. And this here, with the center line discrepancy as well, tells me that there is an early loss of C on one side. What could have been done at that time when she was like 9 or 10 is a balancing extraction of the C on the other side. This would have not resolved the crowding problem, but at least we will have preserved the center line, and the crowding would have been, let's say, more generalized, distributed along the whole labial segment, which is easier to treat than severe crowding on one area only. So we required fixed appliance. We needed lots and lots of work to correct the center line and to bring the lateral incisor in place. Right, premature loss of deciduous first molar. A loss of D. Well, it's the problem resulting from this early loss will depend again on the age of the patient, amount of crowding, size of the jaw, size of the arch, and the sequence of eruption of the permanent teeth, right? So if the arch is well spaced, then the consequences are minimal of an early loss of D. But in crowded arches, we will have usually center line discrepancy, and we will have loss of space with possible impaction of the permanent tooth. In the upper arch, usually the canine will suffer the impaction and loss of space because it is the last tooth to erupt in that area. But in the lower arch, there are, deviation between individuals. Sometimes the 3 is the last tooth to erupt, sometimes the 4 is the last tooth to erupt. So the tooth that will be affected depends on the sequence of eruption. For example, this patient here, the 3 had erupted, but the 4 not yet. So the tooth that will suffer impaction is the lower first premolar. Another example here, a patient with an early loss of D on both sides. You can see here actually partially erupted 4. The reason why is because for this patient in specific, the 4 is erupting before the 3. So if you have an early loss of D, then the 4 will erupt first, and then who's going to suffer from crowding and possible impaction is actually the canine. Okay, so the consequences in the lower arch will depend on the sequence of eruption. Premature loss of deciduous second molar, even if the arch is well spaced, usually what happens is that the permanent first molar shifts mesially. In most of the cases, it will shift mesially, so it will compromise the space for the permanent second premolar, and we will end up having a severely displaced second premolar or even impacted, right? Just forgot to talk about the management for a D, by the way. So if you have an early loss of D, you need to go for a space maintainer. Okay, usually the space maintainer is a band and loop, a type of space maintainer. If it's bilateral, then we can use lingual arch. We can use an arch. Right. So continue with our early loss of E, deciduous second molar. So this is the typical clinical presentation of an early loss of E. This arch, for example, has crowding all around, but the crowding is more severe in the upper left quadrant. The etiology is due to early loss of E in specific. The same for this patient here. Okay, it looks like a mirror image. It's the same. This is very typical. This is very typical for an early loss of E. What happens is that as if the 5 is excluded from the arch, it becomes impacted or excluded from the arch, which means severely displaced. As you can see, we have crowding all around, but here in specific is due to early loss of E. What could we have done? Again, we can use space maintainer, of course. Band and loop. if we have fully erupted 6. We can use, if it's bilateral, if the E that was lost is bilateral, then we can use lingual arch in the lower arch or transpalatal arch in the upper arch. So this is a patient who was lucky, where the E was early lost, and they got to have a lingual arch in order to preserve the space for the second premolar. Unlucky patient, forget about the poor 6. This 6 has poor prognosis, but when you see the 5 here, yes, there's crowding everywhere, I know, but the crowding, the severe crowding specifically here is related to early loss of E. The etiology is early loss of lower left E. Typical, you can see the typical clinical presentation of early loss of E. These patients were not lucky enough to get a transpalatal arch, a space maintainer, so they ended up having severe crowding. This patient here actually, again, not only severe displacement, but impaction. So if you look at the arch, you will hardly believe that there is something missing. But what happened is that both second premolars are impacted, and the etiology is we have early loss of E on both sides. What could have been done when the E's were extracted and early lost? That a lingual arch should have been fitted. Space maintainer should have been fitted in order to avoid such an impaction. Right, so this is a very nice study case. You can see this patient here is presented with many problems, and if we look at the 5s in specific, we will find that all 5s are of severe crowding, either impacted or actually severely displaced. And if you think about the etiology, it's the same. Early loss of E and having no space maintainer fitted properly or at the proper time. The canine here is actually buccally displaced and crowding, and this is not the same as the upper left canine. And the reason why is because the patient also had an early loss of C. How do I know? Look at the center line. Obvious center line discrepancy. You can see actually the center line discrepancy extraorally. So the etiology for this type of malocclusion, some local factors including early loss of E's, all E's actually in all quadrants, and early loss of C in the upper right quadrant. What could have been done to reduce the severity of this malocclusion? Well, balancing extraction of the upper left C and fitting lingual arch in the lower, transpalatal arch in the upper as a space maintainer. This what should have been done. So if you look at this case, you will appreciate the importance of the interceptive orthodontics that could have been applied to this patient. Retained deciduous teeth is another problem opposite to early loss of deciduous teeth. And usually, if you have a tooth that shedded on one side, you need to count 6 months up to 9 months, and then the other side should erupt, and you should lose the deciduous tooth on the other side. If not, then we call this a retained deciduous tooth. So here the patient has bilateral retained C, and as you can see, buccally displaced canines. What happens if this is not early diagnosed and treated? You will have ectopic eruption or even impaction of the permanent teeth. This is ectopic eruption. So as you can see here, this is congenitally missing lateral incisors. We have retained B, C, retained B, C, and you can see that the canines are actually trying to erupt in the place of the lateral. So if this was early diagnosed, then we can extract the B's and wait 6 months, take another radiograph, and maybe extract the C as necessary, if this is really important and necessary. So this is a patient with retained E's, and you can see both second premolars are deflecting from the normal back of eruption. So the management is extraction of the E's and review in 6 months to make sure that the second premolars are actually normalizing in their path of eruption. These are retained C's on both sides, and the reason why, because we have palatally impacted canines, severely palatally impacted, as you can see here, actually, very severe cases. Another important study case, you can see that the main etiology for this patient with such malocclusion is a retained C in the lower right quadrant, causing the permanent canine to erupt lingually, and the retained C in the upper right quadrant, causing the permanent canine to erupt buccally. So if this patient was offered a proper interceptive measures, then the patient could have had extraction of the C at the proper time, and this would have reduced the severity of the buccal displacement of the canine in the upper and the lingual displacement of the canine in the lower right quadrant. Another example of retained deciduous tooth, this is an E because of the congenital missing. So not only a retained deciduous tooth is a result of impaction or deflection of the erupting follicle, but sometimes because we have congenitally missing teeth. Non-nutritive sucking habits, you know the consequences, you took the etiology of such a problem. So an early diagnosis means the diagnosis before the eruption of the permanent incisors. We need to encourage the patient by psychological treatment. This involves positive reinforcement, habit reversal, or reframing. These are the first lines of treatment. Okay. Positive reinforcement is to encourage the patient, give them some rewards. Habit reversal is to give the patient an alternative activity to encourage the patient to stop the habit and have an alternative things to do when they see thumb sucking. Reframing is to change the habit from being comforting and something the patient likes to do into something that is considered a duty. Something not really give the patients comfort by asking them every time they want to suck their thumb, they have to suck the rest of the fingers, for example, the same time. So if they suck their thumb 5 minutes, they have to suck the rest of the fingers. So it's like reframing this habit from being comforting and nice to do into being a burden and it's like a duty, something they don't like to do. So gradually they will have, if they are really, if they believe they want to stop this habit, they will actually respond to such treatment. Other methods also could include the use of plasters, gloves, better flavored agents that are applied to the digit to make the habit less satisfying. Now, these non-invasive techniques could be used up to 3 to 6 months maximum. And then after that, you might use some simple fixed habit breaking appliances. And it looks like a transpalatal arch that is modified into vertically extending loops in order to prevent the thumb from going into that place in the palate that is satisfying and comforting the patient to go for sucking. We use this 6 to 12 months in order to break the habit and stop it. Right, so this was the topics covered for the first lecture. And one article that was published regarding the balancing extraction and the compensating extraction by Rock in 2002 in the International Journal of Pediatric Dentistry. This article was updated and republished as guidelines in the Royal College of Surgeons of England in 2006. So these are extra readings for you if you want to know more about balancing and compensating extraction in cases of early loss of primary teeth. Right? Thank you for listening.